Our next speaker is Dr. Lalitha Nayak. Dr. Nayak completed her medical doctorate in India, residency at Allegheny General Hospital, and adult and hematology oncology fellowship training at University Hospitals, Case Western Reserve University. Her clinical and scientific interests focus on hemostasis and thrombosis, in particular, devastating conditions like antiphospholipid antibody syndrome. Additional efforts in her laboratory focus on cancer-associated thrombosis, and she's here today to share with you new insights on how blood clots form and how we might be able to treat them. Lalitha.
Thank you, Mukesh. I would like to thank the organizers for this opportunity. I would like to start with a case. This was a patient that I saw about a few years ago, and that directed much of my research after that. So IL was a 30-year-old female with a known diagnosis of primary antiphospholipid antibody syndrome. This diagnosis was made when she was diagnosed with an unprovoked pulmonary embolism at 14 years of age, and she has been on long-term anticoagulation since then. She's compliant with her therapy. When I met her, she had already undergone 2 first-trimester miscarriages. She was on her 3rd pregnancy, and her obstetrician had started her on aspirin and therapeutic dose Lovenox for this pregnancy. Everything seemed to go well for her 1st trimester, but in the 2nd trimester, she suddenly developed severe thrombocytopenia, intrauterine fetal demise, and multi-organ thrombosis. So this was diagnosed by noting multiple ischemic lesions on imaging studies in the liver. She had evidence of ischemic heart disease, so in the heart, and then transient ischemic attacks. Diagnosed with catastrophic APS, she was immediately admitted to the hospital and received standard of care for CAPS, which is high-dose steroids and plasma exchange. Please note that she remained on full-dose anticoagulation throughout this period. Despite all these therapies, she went on to develop bilateral renal microvascular thrombosis and lost both her kidneys. She had a prolonged 2-month in-hospital course, after which she was discharged without a pregnancy and without her 2 kidneys. The one thought that remained with me throughout this time was that this lady had all this thrombosis in the presence of known anticoagulant and antiplatelet therapies. So antiphospholipid antibody syndrome is a feared autoimmune disorder that is associated with a high risk of both arterial and venous thrombosis and a high risk for mortality and morbidity. The treatment options are limited at best and include long-term anticoagulation, and recurrent thrombotic events continue to occur even when they are compliant with this therapy. Now, this is an autoimmune inflammatory disorder, and despite the fact that this is associated with a high risk of thrombosis, the role of immune cells in thrombosis is poorly understood. So we sought to do just that. And let me start with hemostasis. So bleeding has been a major cause of death for most of human evolution. And in mammals, a complex set of mechanisms have evolved that limit blood loss after vascular injury, and collectively, these are known as hemostasis. And hemostasis is a vital and very fundamental physiological process to stem this bleeding. This requires what we traditionally understand: activated platelets and coagulation factors. Now, thrombosis, on the other hand, is an aberration, the most feared complication of cardiovascular diseases, and the #1 cause of mortality and morbidity worldwide. And although we have effective antithrombotic treatments, these come with 2 important problems. 1, it is associated with an increased risk of bleeding. Not surprising, because these medications attack our fundamental and vital process of hemostasis. And 2, which I think is even more important, is that patients continue to have thrombotic events despite being on anticoagulation therapy, as we see in our patient. And this immediately and very obviously implicates a third therapeutically unaddressed mechanism, And there is a growing body of data now to strongly suggest, that this third mechanism must be inflammation. Now we know today that there is a very intimate and bidirectional connection and relationship between inflammation and thrombosis, what we now coin immunothrombosis. And there are a large variety of disorders where we see inflammation, and all of these are associated with a high risk of thrombosis. But despite the fact that these are all based on a bed of inflammation, our understanding of the role played by immune cells, especially innate immune cells, is very, very poorly understood. So we set to do just that. I have used two thrombosis models, an arterial model of photochemical injury, where we use rose Bengal dye to cause photochemical injury by releasing reactive oxygen species when this dye is exposed to green light at 540 nanometers. And then we measure the time it takes for an occlusive clot to form. So a prothrombotic mouse will clot in a shorter period of time as compared to a control mouse. And the venous thrombosis model is a stasis model where we tie a suture to completely ligate the IVC, the inferior vena cava, just below the renal veins. This allows for blood vessel stasis. So stasis of the blood, which allows for a clot formation. This clot is then harvested and weighed. So a heavier clot, a larger clot, is noted in a prothrombotic mouse. Now, although these studies have been done at every step for the rest of the studies, in the interest of time, I will only show the data mainly in the arterial thrombosis, with the understanding that the results are similar in venous thrombosis as well. So we started with a mouse model of antiphospholipid antibody syndrome. So a wild-type mouse can be injected with antibodies taken from patients with antiphospholipid antibody syndrome. And these are taken from patients who have recurrent thrombotic episodes. And they were injected at the timeline shown. And on our carotid artery thrombosis assay, we note that this mouse is prothrombotic. So when injected with this antibody, these mice clot pretty fast, much faster than a control IgG-treated mouse. Now, this is a standard model. This is a known fact. So since we were interested, and since neutrophils form a large proportion of the peripheral blood, we wondered what the effect of neutropenia would be and what is the contribution of neutrophils. We found that depleting neutrophils almost rescued this phenomenon. And then if we transferred or transfused these neutrophils in another mouse, we generated and recapitulated this prothrombotic phenomenon. So not only are neutrophils critical mediators, but they are both necessary and sufficient to create thrombosis. And then we wondered whether this can be extrapolated to other inflammatory disorders. So what would we see in other models of inflammation? Now, it so happens that we have a mouse with chronic inflammation in the lab. So let me briefly introduce and quickly introduce a family of transcription factors, cripple-like transcription factors. These are a zinc finger family of DNA-binding transcription factors. They broadly regulate cell growth and differentiation, and there are 18 mammalian KLFs that have been identified. My work focuses on KLF2, and when I joined the lab, it was already established that KLF2 maintains myeloid quiescence. So it represses the myeloid cell from being activated. And what we knew at that time was if you expose, and this is a monocytic cell line on the top left hand of the screen, KLF2 quickly dies. And interestingly, patients with either acute or chronic inflammation have decreased KLF2 levels in their peripheral white cells. So we generated a mouse that had KLF2 deleted specifically in the myeloid cells, so granulocytes, monocytes, macrophages, dendritic cells. And we find that even at baseline, just by deleting one transcription factor, this mouse shows inflammation as evidenced by increased serum cytokine expression. So we wondered whether this mouse would be prothrombotic. And yes, on our arterial and venous thrombosis assays, this mouse clots faster and has a larger clot burden, suggesting that this mouse has a prothrombotic phenotype. So we wondered what happens to our patients with APS, and both in our patients as well as in our wild-type mice treated with antiphospholipid antibodies, we were able to show that the peripheral white blood cell KLF2 expression was decreased. So we thought this would be a good model for us to study and continue with the rest of our experiments. So we had three questions. One, what are the cellular elements that drive thrombosis? 2, what are the mechanisms that are involved in generating thrombosis? And finally, what are the translational implications? What do these mean for us at the bedside? So to answer our first question, we have this mouse where we have KLF2 deleted in these 2 cells, macrophages and neutrophils. And to identify which cell is the culprit cell, we would have to either deplete one of the knockout cells and show that the phenotype is rescued and thrombosis times are prolonged, or we can take that knockout cell, transfuse it into a normal mouse, and show that we can reproduce the prothrombotic phenotype. So our studies showed that neutrophils are the culprit cells, because when we depleted neutrophils, we rescued the phenotype. If you look at the top right-hand corner, removing the neutrophils prolonged the time to thrombosis, and we could take neutrophils, transfuse them into a normal mouse, and recapitulate this phenomenon. Now, removing macrophages or depleting macrophages or monocytes with clodronate liposome did not have any effect. So all of these results suggested that neutrophils are the culprit cells that are responsible for this prothrombotic phenotype. We then asked, how do neutrophils cause thrombosis? There are a number of mechanisms. We find that these activated neutrophils reach the area of endothelial injury far faster than control neutrophils. We find that they generate increased neutrophil extracellular traps, which we know are associated with increased thrombosis, and they also generate increased tissue factor expression and activity. So all of these 3 things are known to be associated with increased thrombosis. Now, for neutrophils to be recruited to the site of endothelial injury, they need a ligand. So we search for that ligand using an ex vivo flow assay where we've lined tubules or channels with known endothelial receptors, ICAM, VCAM, or P-selectin. And on flow-based assays, we were able to find that PSGL1 ligand on the neutrophils are responsible for this recruitment. And if we block PSGL1 with an antibody, PSGL1 antibody, we could reverse this effect. So we thought that was interesting, and we recapitulated this in the mouse now. So we have knockout neutrophils, we incubate it or block PSGL1 with an antibody, and we can rescue this phenotype. So now these neutrophils cannot cause a prothrombotic phenotype. So for cells, for neutrophils to migrate upon activation, they have to switch to a polarized morphology. So typically, the cell, the neutrophil, has receptors or ligands that are uniformly distributed on the surface. When they are activated, these receptors and ligands move either to the leading edge, that is the pseudopod, or to the back end of the business, which is the rear end or the contractile end, which is known as the uropod. Turns out our PSGL1 ligands move to the back end, to the rear end of the neutrophil. And this is important for migration as well. So on our studies, we found that our knockout or activated neutrophils had already prepared themselves and made clusters of PSGL1. So they go to the back end and they're ready, as in now they're waiting to migrate the moment they have a signal. And when these cells were stimulated with LPS, we found that they made clusters of PSGL1 far faster than their control counterparts. So like I said, they are ready to go. So we can block our activated neutrophils with PSGL1 antibody. However, PSGL1 on its own is non-selective because it does not distinguish between an activated neutrophil or a quiescent neutrophil. It does not distinguish between clusters or single ligands. To be able to identify activated cells and only target activated cells with clustered neutrophils, we resorted to a nanoparticle-based strategy where we developed nanoparticles that were decorated with clustered PSGL1 antibodies. And both on ex vivo and in vivo studies, we were able to show that these nanoparticles were far more efficient at inhibiting neutrophil adhesion to the wells that are coated with P-selectin and at reversing the prothrombotic phenotype and prolonging the time to thrombosis in the mouse. Now, importantly, and this I think is really important for me, this benefit in thrombosis was not associated with a prolongation in tail bleeding assay, which means that now we had a benefit in thrombosis without affecting bleeding. What does this mean for us at the bedside? Well, we're still not at the bed, but we went back to our mouse that was injected with antiphospholipid antibodies, and we had shown that injecting the mouse with these antibodies shortened their time to thrombosis. But when we injected this mouse with these nanoparticles, we were able to reverse this prothrombotic phenotype. At the same time, there was no difference in the tail bleeding assay, which means that, again, we're showing an antithrombotic benefit that is isolated from hemostasis. So to summarize, we have shown that inflammatory situations, in this case for us it is antiphospholipid antibodies, are associated with activation of neutrophils that now affect various functions of the neutrophils that all then translate to increased thrombosis. And if we target PSGL clusters, which are at the back end of the business, at the uropod, we can actually decrease thrombosis without affecting hemostasis. And targeting activated neutrophils may present a new paradigm in the management of immunothrombosis. And in some funny way, I would like to hope that we would lead this paradigm from the back. So I've summarized 10 years worth of work in 10 minutes or 15 minutes. Needless to say, there were a large group of people to help me. Stephanie Lapping has been a major part of my work, and Asha and Ken have done most of the antiphospholipid antibody work. Mukesh Jain, my mentor, who introduced me to this line of research, and Andre, my brilliant collaborator who devised these nanoparticles and has always been a source of support. So with that, I'll thank you for your attention, and I'm happy to take any questions.
All right, Lalitha, that was terrific. We have a couple of questions that came in, both therapeutically oriented. And one is, you spoke about PSGL-1 blockade seems to be very effective in preventing thrombosis. And are there any downsides to blocking PSGL-1 or ill effects that might be seen in a clinical setting?
So one would worry, and I've always worried, that blocking PSGL-1, you're blocking an essential function of the neutrophil. And would this be associated with an increases for infections? However, there are already approved, FDA-approved p-selectin blocking agents, which are already used in sickle cell. And so now we're not blocking the ligand, we're blocking the receptor, but we're doing the same thing. And we haven't really seen, and it's reassuring, should I say, that we have not really seen an increased risk of infection in these sickle cell patients. And they are being treated for 6 months. So we have not seen that as yet. So that has been reassuring. But that would be the main thing that I would worry about.
Good. And again, I apologize to the audience, but this is how we are communicating questions. So I have one more that is a breaking question, which is, you spoke about sort of a long question, but let me crystallize it. I think this is what the individual is asking. You showed that antiphospholipid antibodies downregulate the KLF protein. That seems to be potentially important. Are there ways to enhance KLF expression, and would that be a viable therapeutic strategy?
Yes, so yes, there are agents that can increase KLF2 levels, and we have worked on this for the past 10 years. There are factors such as proteasome inhibitors, like bortezomib, that can increase KLF2 levels in neutrophils or in innate immune cells. That can be a longer-term option for sure. For instance, if somebody has a prolonged history of inflammation, and so if there is chronic inflammation, can you use something like this medication to then, to answer this question, I think our nanoparticles have a different role than increasing KLF2. I think directing our therapies to PSGL-1 would be something in a more acute setting where the cells are already prothrombotic, inflamed, and time is of essence, where you block the neutrophil right now to decrease thrombosis. But in the long term, yes, could we consider now remodulating or repurposing these cells so that they can now behave better? And those would be conditions where I would consider something like bortezomib, a proteasome inhibitor that could increase the levels of KLF2 and maybe dial down the activation of these cells.
Terrific. All right. Thank you, Lalitha.